So Mustafa asked me to talk on disconnected pancreatic duct syndrome and the pancreatic fistulae. So I said, I'll try and make it more pertinent. I picked up four cases from the last 2 weeks that I've seen here. And I said, I'll bring those up here and we'll talk about those cases and from there go on. So let's start with the first one. This is a 67-year-old woman who had a large wall of necrosis and was treated with percutaneous drainage 2 years ago with complete resolution of the collection. And she was doing fine for 2 years. And now comes with unrelenting mid-abdominal pain that's going to the back for the last 1 month.
Rajeev,
No,
are we
yes.
are we live or
I
uh,
don't know. Are
Said?
we?
Are we live? Dr. Said, are you there?
Let, let me ask Mustafa.
I think we're not live yet.
Okay.
Gasper, you need Raj. He's going to introduce you and let you know.
Okay. Good. I thought. Okay.
Dr.
Good
Said,
enough.
are you? Hi, Asad. Okay, now we're live.
Wonderful. Okay. Good.
Now let me introduce Dr. Raj to the audience. Dear colleagues, welcome back on our weekly webinar on EUS and Ercp. This time we have a very important topic: disconnected pancreatic duct syndrome and pancreatic fistula. I know you must be coming across with this problem on quite a good number of cases who are suffering from acute necrotizing pancreatitis, and you always wonder whether there's a disconnected pancreatic duct in these patients or not, and how to approach these patients. For this, we have requested Rajeev Attam. He's a director of advanced endoscopy at Kesapant Hospital in Downey, California. I know it's Sunday and this is his family time. He has been very kind to spare his time for Pakistan side of gastroenterology. Raj, all
Thank
yours.
you.
Can start.
Thank you, Dr. Gas. Thank you so much. And thank you, Khalid and Mustafa, for getting me involved in this wonderful webinar series. Uh, good evening, everybody there, and good morning to people in West Side. So the topic for today is disconnected pancreatic duct syndrome and pancreatic fistulae. It's a topic that's very close to my heart, so I really enjoy working with patients with this condition. To start with this, I'll start with a few cases that we saw in the last couple of weeks, and I'll present those cases and we'll go from there and see how we can manage them. So the case one is a 67-year-old woman who had a large wall of necrosis that was treated 2 years ago with percutaneous drainage, and that led to complete resolution of the collection. She did fine for 2 years and now comes with unrelenting mid-abdominal pain that's going to the back for the last 1 month. There are no signs of fevers or any other infection, no sepsis symptoms. She gets a CT scan that shows this large collection in the around the body of the pancreas. Second case is a 36-year-old woman who had an insulinoma in the head of the pancreas. This was causing episodes of hypoglycemia. She saw a surgeon and the insulinoma was removed with enucleation rather than a Whipple procedure. Postoperatively, she dealt with large intra-abdominal fluid collection and a spontaneous anterior abdominal wall fistula. A drain was placed into the fluid collection, and that led to a persistent daily high volume output of amylase-rich pancreatic fluid. Here on this scan, before the surgery, you can see the insulinoma in the head of the pancreas, very close to the main pancreatic duct. And this is a scan about 10 days after the surgery, and you can see large amount of fluid volume in the abdomen, and you can actually see the track of the fluid leading to the fistula outside and the cutaneous fistula. Case three, and this is again the last 2 weeks, a 56-year-old woman with history of wall of necrosis that was managed with endoscopic drainage and necrosectomy. She did well with endoscopy, and transluminal plastic stents, double pigtail, were left indefinitely at the time of cystoscopy after the completion of necrosectomy. She now presents 2 months later with recurrent lower abdominal abscesses. And fourth case that I saw in the last 2 weeks of similar situation was this gentleman with large wall of necrosis extending to the left lower abdomen, who was treated with percutaneous catheter placement. And the collection has resolved, but he continues to have high fluid output through the drain. So what's common in all those four cases? The lady with the surgery, wall of necrosis, treated with percutaneous drain, treated with endoscopic drainage, and this gentleman who's had large collection that was treated with percutaneous drain and has high output fistula now. In all the four cases, one thing that's common is the disconnected pancreatic duct. So what is disconnected pancreatic duct syndrome? It's complete disruption of the pancreatic duct leading to a portion of viable, that is functional pancreas, becoming isolated from the rest of the pancreas. So this causes a loss of continuity between a viable part of the pancreas and the GI tract. And this part of the pancreas that's disconnected has no way of draining into the GI lumen, and that leads to the complications that we see with disconnected pancreatic duct syndrome. This is a classic MRI picture of somebody with disconnected pancreatic duct. You could see the pancreatic duct in the head of the pancreas. There is loss of parenchyma right here, and then you can see the duct in the body and the tail. And this is a resultant fluid collection that you see because of disconnected pancreatic duct. So what causes the disconnected pancreatic duct? The most common cause is acute pancreatitis. And in most cases, it's necrotizing pancreatitis. Chronic pancreatitis can lead to duct disruption. Post-surgical adverse events like our second case that I presented today. And I have seen patients with trauma, especially children with bike accidents, young adults lifting weights and dropping the weights in the abdomen while doing bench press, cancers, malignancy. Prevalence, it's suspected to be as high as about 40% in severe acute pancreatitis, but many times goes unrecognized. Location-wise, the most common location for disconnection is in the neck body of the pancreas. This is the area where there's watershed supply to the pancreas, and here the chances of necrosis and disconnection are high. Also, in trauma, this is a classic area where you can get what is known as a fracture or disconnection of the pancreatic duct. These patients can many times remain asymptomatic and not be picked up, but others can typically present with persistent or recurrent pancreatic fluid collections. Some people can present with acute pancreatitis, and these episodes are recurrent over the years. Others present with the chronic abdominal pain. And if you look at literature, you would see less reporting of these two symptoms with disconnected pancreatic duct, because it's kind of underreported, I believe. We see patients after necrotizing pancreatitis presenting with lower abdominal abscesses from disconnected pancreatic duct syndrome. And some people, like our case fourth today I just showed, present with persistent external fistula. Many times the diagnosis of disconnected duct is delayed again because of under recognition, and it takes a median of 163 days to diagnose DPDS. And again, the most common reason for delayed diagnosis is lack of awareness. It's a disease entity that most of us don't think of initially. So how can you diagnose disconnected pancreatic duct syndrome? Cross-sectional imaging or ERCP. CT scan is usually the first step or the first imaging test that's used. On the CT, you would see area of loss of enhancement in the section of pancreas. It's usually neck or the body, and there's usually a fluid collection around that area if there's a leak of the pancreatic fluid. And you should be able to see a viable or enhancing segment of pancreas above the area of disconnection to show there's a viable segment of pancreas. MRI is more sensitive in picking up ductal abnormalities. And here, as you can see in this MR, there is abrupt discontinuity of the main pancreatic duct. In some patients, especially in children with smaller ducts, sometimes you may have to give secretin to see the ductal anatomy better and figure out if there is duct disruption. ERCP is definitely the gold standard for diagnosing disconnected pancreatic duct, but it's an invasive procedure. Here you could see contrast filling the body of the head of the pancreas with no filling upstream in the body or the tail. So you can see the abrupt cutoff of the main pancreatic duct. Now, you do have to combine the ERCP information with CT scan or MR or EUS to make sure this abrupt cutoff is not from a complete occlusion from a stricture, but definitely from a duct disruption or disconnected pancreatic duct. In this case, because there was some ambiguity, I injected the pancreatic duct above the lack of filling in the body and tail. And here you could see the main pancreatic duct is filling in the body and the tail, and there is actually a leak of contrast down into a collection rather than filling down towards the head. So this is typical disconnected pancreatic duct. The question comes, how do you manage these patients? You could wish and hope that they get better by themselves. So that's called a watchful expectancy. And I've seen patients, especially in smaller hospitals, being managed that way. Or if there is a fluid collection, you can have an endoscopist or IR physician place a drain and have the fluid be drained into the stomach or outside. Or then we could have other complex ways of duct reconnection by endoscopic transpapillary drainage by ERCP. We could try drainage of the disconnected gland into the stomach or surgical management of disconnected gland. And I'll come over these options as we go along. The most common way of managing disconnected duct is the drainage of the fluid collection that occurs right around the pancreas. And the drainage is most commonly done with endoscopic means into the stomach. Conservative management almost never works. You could try octreotide or somatostatin to reduce the pancreatic fluid production, but it almost never leads to closure of fistula or never leads to resolution of symptoms. A word of advice, if you're using watchful expectancy or conservative management, please keep the patients on enteral nutrition because it's been shown that TPN does not help resolve pancreatic disconnected duct syndrome. They actually do better with enteral feeding than TPN. So you could try somatostatin, but almost never works. So then you're actually led to the other options. And if you look at the published case series and the literature, most series describe endoscopic drainage of fluid collections as the management of disconnected pancreatic duct syndrome. So how's this transluminal drainage performed? It could be at the initial presentation of necrotizing pancreatitis or patients when they come back later with recurrent fluid collections. At the initial presentation, if disconnected pancreatic duct is suspected, transluminal stents are left in place indefinitely after endoscopic drainage or necrosectomy. If they come back later and they have an adjacent or adjacent fluid collection, we leave transluminal stents and again leave them for indefinite period of time. And we hope the pancreatic gland that's disconnected will keep draining into the stomach or small bowel across those stents. So this is a schematic of how this is done. This is somebody who presented with a fluid collection from disconnected pancreatic duct. You could see this fluid collection, part of the pancreas. The fluid collection is punctured across the stomach wall. In this case, they've placed a lumen opposing metal stent. You can see the outline right here. We end up leaving plastic stents, which can be left indefinitely. Metal stents, usually we take them out in 3 to 4 weeks. And then these stents can be seen 1 year later. What these stents do is they allow the pancreas that's upstream to the stents to drain across into the stomach. And that's how we took care of this case number one, the lady who had presented with abdominal pain 2 years after her pancreatitis. She underwent Eus Guided Drainage of the fluid collection. Here you could see the puncture of the collection with and a wire coiling within the collection. And we placed a metal stent, a lumen opposing metal stent, and through a plastic stent. Later, the metal stent was removed and plastic stents were left indefinitely. In this case, again, because there was some ambiguity about is the disconnected duct draining into the collection, I actually punctured the duct upstream of the collection just to confirm that the contrast actually goes into the collection. So this is a small clip of that. Here you could see the contrast being injected in the main pancreatic duct above the disruption. And you can see the contrast now collecting within the collection right here. And you would actually also see the contrast then exiting through the metal stent into the stomach. So this is how the disconnected gland now drains. It drains into the collection and through the collection into the stomach. So we leave these long-term transluminal stents, but do they work? This is a study from Shyam's group, and colleague would know this. So 53 patients with a wall of necrosis were treated or randomized into two groups, one where permanent transluminal stents, plastic stents were left, and 24 who did not get transluminal stents. The ones who had transluminal stents, all of them had disconnected pancreatic duct. The ones where these stents were removed, only 13, almost half had the disconnected pancreatic duct. In patients who had transluminal stents that were left indefinitely, the recurrence of PFC or pancreatic fluid collections was 0%. So nobody presented with recurrent fluid collection. While in patients where the stents were removed after completion of necrosectomy, about 21% presented with recurrent fluid collections. So in this study, there was some data supporting leaving transluminal stents when you suspect disconnected pancreatic duct syndrome. But do they really work? So this came from Dr. Bhasin's group at PGI Chandigarh, and they looked at 30 patients who had disconnected pancreatic duct syndrome, and indwelling transluminal stents were left. Total number of cases were 30. In 5 of these 30 patients, the stents fell out by themselves. Of the 5 where the stents fell out, 4 remained asymptomatic on long-term follow-up. Only 1 had recurrent fluid collection. As compared to 25 patients where the stents did not migrate, none had recurrent fluid collection. So again, some support of leaving the transluminal stent, but again, numbers were not big. So, and again, I'll show you this case where not always do the transluminal stents work. So here is somebody I took care of who had a large wall of necrosis. They had endoscopic necrosectomy, and after the completion of necrosectomy, I left transluminal stents forever. You can see the stent right here across the stomach wall into what would have been the wall of necrosis. You can actually see the pancreas upstream to the necrosis area, and you could see the dilated pancreatic duct within the pancreas. And this patient started coming to the hospital with recurrent abscesses in the left lower abdomen. So we followed the guidelines. We left transluminal stents indefinitely after completing necrosectomy, but he would now come with abscesses. So do the stents really work? We're not sure. This is data from University of Minnesota. So they looked at patients who had acute necrotizing pancreatitis over the last 5 years, of which these patients, 66 were identified to have disconnected pancreatic duct syndrome. 44 of these remained asymptomatic, did not present with any symptoms. And this 44 patients who are asymptomatic, 27 did not have transluminal stents. So not having transluminal stents did not really cause symptoms. The patients who became symptomatic, 22, 1/3 of the patients, only half had transluminal stents. So here, it was a toss of a coin that transluminal stents work or not. So data are not very supportive. Now, besides pancreatic fluid collection, now what we are seeing is patients presenting with other symptoms like recurrent pancreatitis, abdominal pain, this fluid collections or abscesses away from pancreas. And if you look at the MRI, one thing that is very obvious in many of these patients is the main pancreatic duct is distended in the pancreas that's upstream to the disruption. So in this case, this is the pancreatic duct in the head of the pancreas. This is the area of disconnection. And if you look at the duct above in the body and tail, it's distended. There's no collection around here. And I believe that we're seeing more of these distended main pancreatic ducts. And I feel it's because the way we are treating wall of necrosis. So this is a patient schematic of wall of necrosis in the body of the pancreas. As we treat it and the necrosis goes away, we're left with a scar tissue. I believe the duct scars right at the point of necrosis, and over point time, it distends. Now, this distension could cause a leak and reaccumulation of fluid around here, or it could lead to abdominal pain because of duct distension here and recurrent pancreatitis. The fact that we're using large size metal stents or lumen opposing stents more commonly in treating these patients with wall of necrosis could be playing a role in these patients developing rapid resolution of collections and duct distension. That's possible too. Now, what happens when the duct is distended in the pancreas above the disconnection? Again, many of them remain asymptomatic, do not show up with symptoms, but over time may develop progressive atrophy of the gland, and this could lead to diabetes. And this was actually shown in a recent study. Some present with recurrent collections or abscesses, like our patient that I showed the CT scan for. Others, and these abscesses that drain by IR can lead to external fistula. Others present with recurrent pancreatitis, and it becomes a diagnostic dilemma because how do you treat these patients? And some others present with chronic pancreatitis or a persistent abdominal pain. And it's these patients where there's no fluid collection, but they're presenting with recurrent pancreatitis, abdominal pain, or fistula, that the management becomes difficult. And that's where Khalid or Mustafa get a call as to how to manage them. So what do you do for these patients? Again, if there is a fluid collection that can be accessed across a stomach or bowel, small bowel, leaving transluminal stents for accessible collections is the option, the best option. But many patients do not have that option. When there is no fluid collection, then your options become limited. And what we've tried is duct reconnection, either through Ercp or Eus guidance. Eus guided duct drainage into the lumen of the stomach or small bowel, and I'll show you pictures of that. Or in some cases, complete occlusion of duct in the disconnected glands. These are all endoscopic options. Besides that, we have the surgical options where the disconnected or separated part of the pancreas is removed surgically, or that part of the pancreas is connected to bowel through a duct drainage procedure. ERCP duct reconnection, it is tried by passing a catheter into the papilla and trying to get a wire across the disconnected area or the necrosed area into the gland upstream to the disconnection. It involves leaving a transpapillary stent, and the stent has to be left in for long term because there is this disconnected area in the center that is not epithelized. And as you take the stent out, it'll stricture down again, and you'll have the same problem again. So here is an example of somebody with the same method that we used. So this is a patient, 51-year-old male with severe necrotizing pancreatitis. He also had splenic vein thrombosis leading to large gastric varices, and he was presenting with recurrent intra-abdominal abscesses. CT and MRI showed necrosis of pancreas neck with viable pancreas upstream to the necrosis. So we tried attempting ERCP guided duct reconnection. Here you would see the wire across the papilla into the main pancreatic duct in the head of the pancreas. As you put contrast, the contrast just spilled into the area of this necrosis where there's loss of pancreas, and there was no filling of the pancreatic duct upstream. We passed bidirectional bending cannula into the collection and using an angled wire, tried to poke at the area of duct upstream to the necrosis. And I would say, luckily, we're able to find the main pancreatic duct of the gland that was disconnected. And you can see the wire going in, injected contrast to confirm that the wire is in the main pancreatic duct upstream to the area of disconnection. Again, here, this is the head of the pancreas, loss of pancreas, and the gland upstream. Placed a transpapillary stent connecting the head with the body and tail of the pancreas. The stent was exchanged a few times, and then 3 months later, you can see a duct in continuity. But again, this patient required stent exchanges every few months for almost 2 years, because I was worried if I take the stent out, he would have complete occlusion at the site of disruption. But this saved him a big surgery. He was able to come out of the hospital, did not have any more fluid collections, and got back to work. So that was transpapillary approach using ERCP, but it works only in a handful of cases. The other option now is the Eus Guided Approach, where we reconnect the duct using Eus techniques. This technique involves connecting the ducts of downstream and upstream of the disruption. It requires a combination of both Eus and ERCP, so you need to have the expertise in both the procedures. But also, it requires long-term stent therapy because, remember, there's this area of loss of pancreas in the middle. So there is no duct there. And if you take the stent out, this would shut down again. So this is a schematic of how it works. This is a patient with necrosis, head of the pancreas with a viable pancreatic duct, loss of body, and this tail of the pancreas. It involves puncture of the duct upstream to the disruption with the Eus guidance. We get a wire across and maneuver the wire through the disruption into the duct downstream. It looks easy on the schematic, but believe me, it is not. So once the wire has been placed, we leave the wire in place, follow the wire with the ERCP and get a stent across and leave the stent for long term and allow the pancreas upstream to the disruption to drain down through the stent. This is a video we presented a few years ago. Mustafa and I worked on it, of a patient we treated this way, a 53-year-old male with necrotizing pancreatitis and wall of necrosis that was treated with the endoscopic necrosectomy. We had left the transluminal stents in place to drain the pancreas upstream because we knew there was duct disruption, and the plan was to leave the stents indefinitely. And he now started coming with recurrent lower abdominal abscesses. We tried ERCP, and there was complete disruption of main pancreatic duct. So this is an abscess in the left side. Transluminal stents are in place. And we did a fistulogram. The fistulogram showed the connection of fistula abscess to the pancreas. So in ERCP, you could see the duct was filled in the head of the pancreas, and then it started spilling out. Duct upstream, the disconnection in the body and tail did not fill up. This is a cystic stent that was left after completion of necrosectomy. The stent is still there. So here you can see the contrast leaking out outside into the area of necrosis, but not filling the pancreas upstream. There's also another leak from the neck of the pancreas down. So we tried Eus Guided Duct access. So this is the pancreas upstream in the tail of the pancreas. Necrosis would be somewhere around here. This is the main pancreatic duct in the pancreas that's disconnected or separated from the head of the pancreas. You can actually, oops, sorry. Let me go back. So here you can actually see the main pancreatic duct coming to the necrosis. Right here is the necrosis. The duct measured about 3.7 millimeters in the body above the necrosis. So the duct was punctured using a 19 gauge needle. And here you can see the contrast in the main pancreatic duct. Cystic stents in place, contrast leaking out into the collection area. So we tried getting a wire through the duct. Here you can see the main pancreatic duct is filled up with contrast. Complete occlusion right here. This is the area of necrosis with the cystic stents. Contrast fills the body and the tail of the pancreas, but the head of the pancreas is not opacified. Again, confirming disconnected pancreatic duct. So we pass a wire, the wire just gets stuck at the area of necrosis right here. So using different kinds of wires, we were able, so first we left the wire in the duct and we got a balloon in, dilated it, and then we're then able to push the wire into the necrosis area. Here you could see the wire is left into the necrosis area. That's where the cystic stent is. So we have a wire that's coming from the stomach into the pancreas and into the necrosis. So we left a stent that comes from the stomach into the main pancreatic duct and ending into the necrosis area. These are the cystic stents. So the main pancreatic duct is now being drained into the stomach. So we went a step ahead and tried now cannulating the main pancreatic duct from the head to see if we can join the two. So we did an ERCP right then and cannulated the main pancreatic duct in the head. And you could see the main pancreatic duct. This is a stent coming from the stomach into the necrosis. And then we got a wire to slide besides the stent that was placed by EUS, and then the wire we passed all to the tail of the pancreas. So this way we were able to reconnect the head and the tail of the pancreas across the necrosis. Left a stent across, and here you could see this is a stent going from the papilla into the head, across the necrosis, into the main pancreatic duct of body and tail. This is a stent that was placed across the stomach into the main pancreatic duct. So the stent that we had placed across the stomach into the main pancreatic duct gave us the marker to aim the wire at. And using this marker, we were able to find the duct and get the wire to the tail. So this way we were able to connect the two parts of the pancreas. And on follow-up, we remove the stent from the stomach. This is our main pancreatic duct stent here. Remove the stent from the stomach. And there you go. So this is now two stents going from the papilla, head, necrosis, body and tail. Duct is reconnected. As the duct was reconnected, he stopped leaking into the abscesses. The abscesses then resolved. But again, this requires long-term stent therapy because there is loss of parenchyma in the middle. So that was duct reconnection. The first case was Ercp guided, second was Eus guided. Again, they're complex procedures, do not always work, and you can just hope and try that they will work. If that fails, what is the other option? Other option is you can actually drain the main pancreatic duct into the lumen of stomach or small bowel. Again, this is when there is no fluid collections around. So this is called EUS guided duct drainage, and it again requires EUS puncture of the main pancreatic duct across the gastric or duodenal wall, and we then leave stents, plastic stents for long term. Again, there are a few reported cases. Technique, procedure requires a lot of EUS expertise and some fine wires and balloons. This is the case number 2 that I had shown earlier, the lady with the insulinoma who had the enucleation main pancreatic duct. She developed disconnected pancreatic duct after surgery because of the, when they took the insulinoma out, they took a piece of main pancreatic duct out. And she had presented with large fluid collection with spontaneous fistula to the skin. So this patient, because there was no collection around the stomach that I could drain with stent, everything was lower down. I went for EUS guided duct access and drainage into the stomach. So the main pancreatic duct upstream to the disruption would be somewhere around here, was accessed using EUS. Put contrast in the duct, and you could see the contrast leaking out here. The main pancreatic duct should have drained into the head of the pancreas like here, which is not filling up. Contrast is leaking around. We placed a wire into the main pancreatic duct, and I pushed it into the area of leak. Over the wire, we placed a 3 French stent, a long 3 French stent, and we placed it such that the pigtail went in first, and the straight end was into the stomach. Usually we do it the other way when you place stents. The straight end goes in first and pigtail is in the lumen, but here we reversed it. So you can see the pigtail going into the area of disruption, main pancreatic duct, and then coming into the stomach. This is a stent coming in the stomach. And this helped by draining the disconnected pancreas into the stomach. This led to the resolution of necrosis of the collections. So here you can see the stomach, stent coming in, going into the main pancreatic duct. This is a coronal view, stomach, disconnected pancreas, stent going in. So this stent drained this disconnected pancreas into the stomach and led to resolution of fluid collection in the fistula. As you remember, this is a CT before we intervened. And this is, I think, about 3 months later. The fistula closed spontaneously, all the fluid collection resolved. She had no other issues. She's doing very well. She came back for a follow-up 2 weeks ago and is, again, asymptomatic. So this is one option of draining the disconnected gland into the stomach. It may not be a durable, lifelong option in some of these patients, but at least buys them time to recover from surgery. Like in this case, the fluid collection is resolved, the inflammation of the pancreas has subsided. So eventually, if she does go for surgery, the surgeons will be able to do a much better job than they would have done with this acute inflammation. So do these patients who undergo Eus-guided pancreatic drainage, what is the efficacy of this procedure? There's just one study of 20 patients that I saw where main pancreatic duct was drained using plastic stents, of which half of them were in anastomotic strictures after Whipple, and the other half were in chronic pancreatitis. Um, Stent dysfunction in long-term follow-up was seen in about 50% cases, and this was after almost 3 years of follow-up. But there was resolution of pain in 72% of patients who underwent US-guided pancreatic drainage. So it is a good option, at least for short term, where you can get the inflammation under control, the leak under control, and in some patients, it does lead to a long-term resolution of symptoms. There's another way that's been described in the past of draining disconnected pancreatic duct using ERCP drainage. It's a technique that's it's not that very popular because of very low success rates. Uh, Basically, in this, we leave a stent across the papilla into the area of the collection. And as the collection resolves, the disconnected pancreas drains through the collection tract into the papillary stent. And I'll show you a schematic of this. This is the area of necrosis, head of the pancreas, loss of duct here, main pancreatic duct in the body and tail. What we do is we leave a stent that goes into the collection, and we leave it for a while. As the collection subsides, the stent basically leads to formation of this tract, and the main pancreatic duct upstream to this connection drains through this tract into the head and then to the bowel. Does not work because this tract is not epithelialized, does not have epithelial lining. So once the stent is removed, this actually collapses, and we have two separate glands then. Ablation of pancreatic duct, I've tried in one case, and I'll show you what the thought process was. In somebody who had disconnected pancreatic duct, did not have pancreatic fluid collections, there was no option for draining of fluid collection into the stomach or small bowel. The gland was the disconnected part of the pancreas was in such a position that I could not drain that into the stomach also with the US guided stent placement. And this was only a few months after acute pancreatitis that they were not candidate for surgery. We thought of occluding the main pancreatic duct in the disconnected pancreas so that they stop making fluid, and hopefully that'll preserve. So the process involves complete occlusion of main duct and side branches in the disconnected gland by injecting hysteracryl or N-butyl 2-cyanoacrylate, the glue. It leads to loss of production of fluid in this disconnected gland while preserving the islet cell production, because even if you ablate the exocrine function, the endocrine function of that disconnected gland is still preserved. In this technique, the one has to worry about pancreatitis of disconnected gland. This is a case of a 56-year-old woman who, let me go back, who came in, who had a wall of necrosis and was managed with endoscopic drainage and necrosectomy. As per guidelines, we left transluminal cystoscopy stents indefinitely. She did have disconnected pancreatic duct syndrome. And then now she started presenting with recurrent right lower abdominal abscesses. So here I'll show you the CT scan. This is the collection that she had presented with, necrosis, and she had been treated with transluminal drainage, stent placement, metal stent placement, and the necrosis then resolved. And this is a follow-up CT scan where you can actually see, oops, sorry. So if you look at the follow-up CT scan, um, these stents were still in place. And now she's presenting with collections on the right side, like an abscess on the right side. And she had multiple admissions with right-sided abscesses. And you can see the stents are still in place right here, the ciscus rosary stents, and the main pancreatic duct that was above it was dilated. Here you can see the gland that's disconnected or above the disconnection. And this is the main pancreatic duct that is distended in the gland. So we tried ERCP to see if we can connect the two parts of the pancreas. And on ERCP, we could not connect the two parts of the pancreas. The contrast would go into the main pancreatic duct in the head and then just leak out. We tried Eus guided reconnection, and I could not get the wire to connect the two parts again. So this is where we thought of doing glue injection. So we access the main pancreatic duct in the gland that's disconnected in the body and tail, injected contrast, and you could see the contrast leaking out into the area of necrosis or disconnection, and through that it actually comes down this track, and this is a drain that is put into the abscess percutaneously. So this is the body and tail of the pancreas, loss of pancreas right here, and this is the fistula tract that's leading all the way down to the abscess, and that's the percutaneous drain. So we got a wire through the main pancreatic duct and maneuvered it across the fistula tract into the abscess that's being drained by percutaneous catheter. So this here is the wire going through the stomach into the pancreas duct, through the fistula tract, all the way down to the skin area where the abscess is, and this is the percutaneous drain. The wire was then pulled out from the abscess tract, from the abscess using a snare. So now we have a wire that's going through the stomach into the fistula tract and being brought outside the skin. Over the wire, we pass a small balloon and we reach the pancreas. And now we have a second wire that's going into the main pancreatic duct in the tail of the pancreas. So this becomes a working wire now. We passed those 3 French catheter into the tail of the pancreas, and we injected a lot of contrast to figure out what is the volume of duct in the tail of the pancreas. Once we had estimated the amount of volume in the tail of the pancreas, we created the solution of histoacryl, or the glue. So this is the tail, and we went all the way to the end to see how much pancreas was left. So here we are mixing histoacryl with lipoidol, and then we actually tested how long it takes for it to solidify by putting it into water. And it took about 7 to 8 seconds, I think, for the glue to solidify when put in water. So we knew how much time we had to inject into the pancreas. To here. So we injected the glue through the catheter we had placed into the main pancreatic duct, and we injected with force. So we wanted to opacify or push the glue into every small duct of the pancreas that was disconnected. So this is the gland that's disconnected, that's making the fluid that's causing the abscesses. So the glue and with the radiopaque lipoidol mixture is injected into the main pancreatic duct of this disconnected gland forcefully so that it goes into every small branch. And as it was injected, we also injected the glue into the fistula tract, and we slowly brought out the catheter from the skin. She was kept overnight for observation. She did have abdominal pain after that, but this is this X-ray right after the procedure. You can see the entire gland that's been opacified, like it's been like the ducts have been cemented with glue, and this is the track with the glue within it. This is her CT scan after 1 year. Because the ducts were occluded, the gland in the body and the tail got atrophied. It had already stopped making fluid, so she did not have any more leak that would cause abscesses. So the abscesses resolved. She kept making insulin from this gland because the endocrine function was preserved. We only took care of the exocrine function, and the gland atrophied over time. She hasn't had any more admissions for abscesses, and she's done well. So this is again one case not to be tried unless you know really need to. So the treatment of disconnected pancreatic duct depends on the clinical presentation. Most common presentation is um, patients who present with recurrent fluid collection. In those, it's easy. You can put transluminal stents. When they adjust into stomach duodenum, placement of stent is easy and you let them for long term. When they're not adjacent to stomach or duodenum, Eus guided drainage becomes difficult. So here we then advise doing Eus guided internal drainage disconnected pancreas by leaving a stent across the stomach or duodenum into the disconnected pancreas itself. Or you could try transpapillary drainage if accessible. But again, endoscopic options are, in these cases, I think, temporary. They don't give a durable or long-term resolution. So one does have to think about surgical resection of the disconnected pancreas or drainage through Roux-en-Y procedure. When patients present with recurrent pancreatitis because the duct is obstructed in the disconnected gland, you could try Eus guided internal drainage. Like that lady, we put 3 French plastic stents from the stomach into the pancreas. If that fails, surgical resection of the disconnected pancreas with islet autotransplant, if that's available, that'll help reduce the risk of diabetes. Again, if the duct is big enough, then internal drainage with surgical procedures is another option. Patients who present with percutaneous fistula without PFC, like our fourth case that I'd shown where they had drainage from the IR catheter site. In these cases, again, your options are you could internalize that collection by using EUS, or you could try EUS guided duct reconnection, which works in some patients, is again technically very difficult. Surgical options are again the fallback options. Summary, I would say it's not an uncommon complication of severe pancreatitis, but it's usually not recognized, or if it is recognized, there's always a delay in recognition. Clinical presentations include recurrent fluid collections, but also pay attention to recurrent acute pancreatitis and persistent fistula, abdominal pain. These symptoms get ignored. Endoscopic treatment options include drainage of fluid collection when a fluid collection is present, or drainage of the distended pancreatic duct into the small bowel or stomach. Again, and other options are duct reconnection. And I would emphasize one more time, endoscopic options are not durable long term, I would say, because you need to have a stent in for a long time and patients may not prefer that. But they do buy you time. They do allow the inflammation to go on down. They do allow patients to recover before they go for surgical therapy. Thank you. That was it.
Thank you, Raj. It was an excellent presentation. You've been doing lots of daring work. That
Well,
was
thank you.
taking, how many times have you been brought to the court for doing this kind of daring work?
None so far, because again, when they come to me with these symptoms or these presentations, they've been through every other option. And each case that I presented, before I did an endoscopic treatment option, they were presented to not one, but two, sometimes three surgeons who turned them down. Um, Doing surgery in acute pancreatitis within a month or two of acute pancreatitis, one, or doing surgery in patients who have persistent fluid collections, persistent abdominal, persistent inflammation is very difficult. So all surgeons want, the inflammation to subside before they go in. And many of these patients have had a long course of pancreatitis, and they do not want to go under scalpel again. You recovered after staying in hospital for 6 months, and now the surgeon says that I'll have to take your pancreas out. It'll take another 3-4 months of recovery. They say no. So these are the cases where either surgery was not the first option, two, the surgery was not feasible, three, the patients did not want surgery, but they were all taken for endoscopic options only after exhausting surgical opinion.
And how do you make a fistula between the stomach and the pancreatic duct? Do you use the cystotome, or you use the thin?
Yeah, that's a very good question. So we have a drawback here, that a disadvantage in the US, that we don't have the 5 French or 6 French cystotome that's available or other parts of the world. Our cystotomes are 10 French, and that's, I think, is too big to puncture into the pancreas. So we use very small size 4 French balloon dilators that are borrowed from interventional radiology. So they're just long enough to fit through the scope. They're very small, and they are able to get me enough dilation that I can get a stent in. Um, they're like 3 millimeters of size, very small balloons.
Mm-hmm. And are they tapered?
They're tapered, yeah. So they can slide over 0.18 wire only, or 0.14 wire sometimes. So you need to have a very small wire, and over that the balloons slide over easily. The normal balloons that are used for GI tend to get hung up at the stomach wall. They don't slide in easy. In those cases, then you'd use a needle knife to make a small hole. I don't like burning the pancreas, so I avoid cautery if I can.
Okay. Now, what are the exact indications of sending the patient for surgery? When will you like to send the patient for surgery in
So,
case?
I have a discussion with them I tell them, like, my goal is to get them better, get the inflammation under control, get the fluid collections under control. And I tell them, once everything's settled down and you recovered, I want you to have this conversation with surgeon, whether you want to continue with endoscopic stent changes, you know, or endoscopic options, or at some point, do you want to have resection of the disconnected gland? So they do talk to the surgeons. I have had patients who, after a year or two, gone for distal pancreatectomy, and the surgeons were happy that the inflammation had gone under control before they took them for distal pancreatectomy. But I also have patients who've done well for the last 7, 8 years and not required surgery. The person I reconnected the duct with ERCP had what is known as a PPP syndrome, pancreatitis, polyarthritis, panniculitis syndrome, and he's asymptomatic for 8 years now, not require surgery, and he's even not requiring stent placements anymore. So he's doing well.
Yeah, that it turns people that the nature comes to your rescue, because I'm also able to recall few patients where I was not able to go across the structure at the disrupted pancreatic duct. I was not able to go across, and I just left the stent at the mouth of the fistulae opening, and left the stents there for a couple of months. And once the stents were removed, the patient did well without any
Sure.
recurrence.
Recurrence, yeah. Yeah, so that's, I think, if it works, it's actually a very nice way of treating it, because then it requires least amount of intervention, and the disconnected gland keeps flowing through that path that's formed by the stent.
Yes.
Yes, Dr. Saab.
Hi, Rajeev. It was an excellent talk. Very difficult topic.
Thank you.
Um,
Thank you.
Just taking Vyas's point further, the downstream drainage with the stent, it works in our experience, in a lot of time. Now, could that be explained because of the would that difference could that be explained because of the etiology? The etiology of the pancreatic fistula actually make it more difficult to treat, or this particular technique that Vyas was talking about, and you mentioned Shyam's results, which were not as good. In our experience, the results are pretty good, and I don't know whether it's because of etiology or what.
My feeling is that it works when the duct above the disruption gets scarred. So like in this, try to show like, so once you've taken the stent out, if this gland is not draining at all, meaning the duct has scarred right at this point, then it works. If the duct is not scarred right here and is still leaking, then it doesn't work. Because if the fluid is coming out, your fistula, the tract that the stent formed is again not epithelialized. It will not stay open. Okay. So the fluid has to find some egress somewhere. It'll either form a fluid collection, an abscess, ascites, any of these. But what happens is you've left the stent in for long enough. The duct kept draining through the stent. It gave this pancreas time to atrophy down a bit. When you remove the stent, the duct was scarred here, pancreas a bit atrophied. So again, it's not making that much fluid. You're not getting the abdominal pain, recurrent pancreatitis, and you're not getting leaks anymore. So I think that's what it is. And it is very similar to, I think, they were using the same technique in Europe for chronic pancreatitis too, where they had patients with strictures and they would leave a stent for 2 years at a stretch. And my feeling is when they were not exchanging stents for 2 years at a stretch, what they were doing is basically leaving an occluded stent. Occluded stent would cause atrophy of the pancreas. So when they took the stent out, the pancreas was already atrophied. So in that technique, like in Shyam's paper, again, the reason some people do well is because the gland above is already atrophied and the duct has strictured, so they're not leaking anymore. I don't know if that makes sense, but that's again my hypothesis.
I think it could go the other way too.
That might be explained by etiology as well. Etiologies may have something to do with it too.
There may be, because if somebody already had a chronically damaged gland to begin with, and they were not a large producer of pancreatic fluid, your chance of getting leaks and abscesses are lower, as compared to somebody who had a healthy gland, had acute necrotizing pancreatitis, the gland, and you have a large volume of gland that's left, and they're making a lot of fluid, then the fluid has to find a way somewhere.
Just one more question. You showed a very nice histoecal injection into the fistulous tract as well as the pancreas. In that particular case, you did not attempt draining it into the stomach?
I tried. It was just the anatomy was such that the gland moved away from the stomach, and I didn't have a good window where I could get a stent to go into the stomach. So that would have been my first option, actually. But because of the anatomy, the stent was like in this case, say here, the stomach, I can get a stent like this, but if the pancreas is further away and the disruption is at a point that I can't really get a stent in for a length into the pancreas, then I would not be able to do it. So it all requires, proper orientation of the gland. The problem that we have with the EUS scope is that the needle comes out at an angle. So you really need the angle of the scope and the needle. So you need that room to put the stent in.
Your preferred needle, 22 or 19?
For drainage, So if I'm using a 018 or 014 wire, I would go for a 22 gauge needle. If I'm using 035, 025 wire, then I go 19. Many times I would go with a 19 and then downsides wire. So it all depends. It depends on the size of the duct in the disconnected gland. If it's a small duct, like 1 or 2 millimeters, if the duct is leaking out, then it'll be small. It's generally not distended because it's decompressed. So if it's a small duct, 1 to 2 millimeters, then I would go with a 22 needle. If it's a bigger duct, 3 millimeters above, then I would go the 19 gauge needle.
Right, there's a question from Dr. Kamran. Is there any comparative data available for endoscopic versus surgical measurement of
None. There are none. There are very few studies on disconnected pancreatic duct, and again with endoscopic maneuvers, we're again only few case series here and there. There's never been a randomized trial or a comparative study between the two. And again, it's
Ali Naqvi being a surgeon, he wants to know, will you like to send the patient to me early or late? And
I would like to send them to you early, Ashley, so that you can say that, well, I would like to wait, because I'd rather have the surgeon's blessings before I embark on high risk endoscopic maneuvering. And the patients, my feeling is the patient should always have the option. They should always have discussed the treatment options with the surgeon before they make the decision to go endoscopic route. Then they have
of surgical cystogastrostomy in disrupted pancreatic duct syndrome. Does it have?
It does. Again, all depends on if there is a fluid collection that is accessible across stomach or duodenum, or even duodenum, I would say, I would prefer endoscopic option, because we could do the same work as a surgeon would. If there's a fluid collection that is not accessible by endoscopic options across stomach or duodenum wall, then you have the option of surgery. But if something is accessible, I think endoscopic options are preferred, less invasive. Problem.
Sorry, Raj, you wanted to say something?
Yeah, problem comes when there is no fluid collection and the duct in the disconnected gland is very small. So like the lady I showed you with the enucleation, who had a small duct, this one. So this is a small duct in the head and the body and tail again. She was leaking, and it's a 1 to 2 millimeter duct. No surgeon would be comfortable doing a duct drainage procedure. In her case, yes, resection is an option, but the disruption is right in the head. So either she goes for a Whipple, and then there's a distal gland that's coming across the portal, which is a long, so they'll have to kind of be careful with that. Or if she goes a long distal pancreatectomy, it'll saving the head. Both options are bad for her. She'll lose a lot of pancreas, and somebody who is 36, has a benign condition, is just recovering from first surgery. Does she want to go for Whipple? No.
Ali, do you want to say something?
Yeah, so just first, thank you. It was an excellent talk, and really enjoyed it. One quick question. Let's suppose the patient has a necrotizing pancreatitis, ward of necrosis or collection, whatever. You do a transluminal drainage. Down the road, a few months later, a couple of months later, everything is resolved. You take the stents out. It's time to take the stents out. At that time, do you give patient a chance and not do anything else, or you do a ERCP to make sure they don't have a disconnected duct?
So if I put plastic stents in, I don't bring them back to take them out.
Any necrosis.
Any necrosis.
Okay.
I don't. My feeling is that if I put a plastic stent in, if the stents have to fall out, they'll fall out. If there is a persistent collection that's being fed by a disconnected gland, the stents will tend to stay. Okay. Even if there is no persistent collection and there is no disconnected gland, I'm okay leaving 2 small plastic stents in that area forever. Most times they'll fall out. Okay, so I don't bring them back. I don't even get a CT or anything after they've necrosis resolved and they're asymptomatic. I just leave them alone.
And nowadays, we like a majority of us, or maybe most people, we are doing a metal stents, transluminal, lumen opposing metal stents. Majority of because it's easy, it takes less time, and that. And in those cases, obviously, we got to remove those soon.
Yeah. So my protocol is, say, if I do like, again, things change, but say a typical run-of-the-mill case, if I puncture with lumen opposing metal stent, I bring them back in 3 to 4 weeks. I used to bring them back in 6 weeks till your paper came out and everybody started shouting. So I bring back 3 to 4 weeks. I complete necrosectomy, wash off, everything's done. I've taken the metal stent out. I leave 2 plastic stents and then say goodbye. And I follow them in the clinic. I don't even get scans or other imaging unless there is any reason to. But this is when I've done with the necrosectomies and all. Hey, Mustafa?
Yeah, so excellent talk. And obviously I've learned a lot from you, Raj, over the years, and some really high-end work here. I'll just give a couple of sort of comments on the surgical question. At our previous institution where Raj and I were together in Minneapolis, the surgeons deferred therapy surgically to us and said, if the patient, in your opinion, does not have any other endoscopic options, we should go for surgery, but try and see if you can subside the inflammation with endoscopic therapy, and it makes surgery easier for us. The question of a surgical cystgastrostomy early in the course is one that comes up often, like in early necrotizing pancreatitis, should you do it? At my current institution, there is a surgeon who is very pro surgical therapy for necrosis. And what we've found over the course of time is that they still have these issues. You can do a surgical cystgastrostomy and they can still present with recurrent acute pancreatitis in the disconnected portion. And they can also still have issues with their dilated duct. And we've had surgical cystgastrostomies closed down for us to then go in to do endoscopic therapy. So it's not to say that surgery doesn't have a role. It's more to say that maybe in the algorithm, surgery should be the final resort as opposed to early surgery.
And if you look at adding to the point, if you look at the published series on surgical resection of disconnected gland, even in those series, as high as 20% continue to have recurrent fistula or fluid collection. So when they resected the disconnected gland, they still left some in because the inflammation was still present, and for a surgeon to identify the gland completely was difficult.
It's challenging.
So you have to have the inflammation under control, fluid absent, patient recovered, in better surgical, health for them to go through a uneventful and a better surgical outcome.
Yeah. And the second comment, I think my stance on two things has maybe changed a bit. I actually personally feel that it's good to do an ERCP early on and to do it during the acute phase. When there's already inflammation and there's a less likely chance of you causing pancreatitis from ERCP, to actually look to confirm whether you have a disconnected duct or not, because there have been occasions where I was convinced that it's a disconnected duct, did an ERCP, and it was actually a duct leak. And so there we were able to bridge, put a stent in, bring them back on follow-up, and the patient basically had resolution of the collection as well as the leak. And so you could argue that maybe that patient, even without the ERCP, would have healed up and not necessarily needed the ERCP. But if they were going to form a stricture at the leak, that was taken care of. So to distinguish a disconnection from a disruption with a leak, I think early ERCP tends to be safe, but obviously we're doing pancreatic ERCP, so the risks have to be considered. And secondly, along those lines, I think leaving in plastic stents for now is still a better strategy. I think you mentioned this series out of India from the Hyderabad group, where they're actually proposing not leaving double pigtail stents long-term after metal lumen opposing stents. But
they're saying they may not. They're saying they may not be needed.
Yeah.
So again, because my feeling is that many of these actually fall out. Doing a second endoscopy to take them out, I don't see a sense in doing it, you know. But if there is any suspicion, there are some data that maybe they work, you know,
Yeah.
so we'll leave them in. It's a benign thing, doesn't cause much discomfort. So, and they're cheap, you know.
Yeah. But I think there are opportunities for studying this endoscopic approach and optimal timing of endoscopic evaluation with ERCP, especially if you just look at the people who are logged in right now, like between Dr. Sadniaz, Dr. Rias, your center, Dr. Hassan, if all those centers came together and compiled the data and actually looked at the denominator too, how many patients actually presented with necrotizing pancreatitis, how many of them got ERCPs, how many got transluminal stents and transpapillary stents, and what the outcomes were, this would be a series over like 400 patients in just like the last few years, and that would give some really meaningful data. So I think one of the things that comes out of these conferences is ideas for collaboration and potentially answering some of these difficult questions.
Yeah.
But excellent, thank you very much for this very insightful presentation.
Excellent, Raj. It's already 20 minutes past 6 in Pakistan, and I can see that you are in your working dress, and so is Khalid on Sunday morning.
We are just waking up. I'm fasting. I'm trying to get the day.
Khalid is always in that dress, whether he's at home or whether he's at work. He's always like that.
You know, most of us go to work. Khalid goes to home. So, yeah. And then, so just for everybody's knowledge.
Well, it remains for me to thank everyone. Thank Raj in particular for
spending this time. Thank you, guys. Thank you, everybody. It was a pleasure.
And thanks to all the participants, and thanks to Wilson Pharmaceutical as well for giving providing the platform. So see you next week. Take care. Allah Hafiz. Bye bye.
Take care. Bye bye.